Oh, hey, Chris.
Hey Chuck, how are you?
It's a special night.
It's a special night. Our most popular guest is back. Macy Stoner.
The
Welcome, Macy.
OG, the
The OG.
OG.
I'm
Exactly.
here. Thanks for having me.
So excited. So many people in the show survey have requested more Macy. So we're finally here, and she was so kind to make it on relatively short notice. So thank you. I know your house is quite busy, so a weeknight is a challenge.
Hey, 8:07 p.m. Everybody's in bed and I'm good to go.
Okay. Lucky
We're
you.
we're just tired of hearing more Macy, more Macy, more Macy. So we're delivering for the podcast lovers out there, and we are happy you are here. Thank you.
Of
So
course.
speaking so for today's episode, we're going to go through if somehow people wanted to talk about this, but rehab protocols and general approaches to lateral epicondylitis slash tennis elbow. I think we teased them with the how we think about common conditions, and I guess people want to talk about that, so are happy to oblige.
It's gonna be fun. It's gonna be fun.
Yes, Macy's got a project going right now where she is trying to disseminate rehab protocols for a number of things, but including free functioning muscle transfer, which is in the plexus world and also is used in other applications. And then Macy's got an exciting reveal regarding something that every hand therapist and every hand surgeon who listens to this is going to want to know about and add to cart. So we'll leave it at that. But our first thing to talk about is a review that we got from one of your colleagues in Dallas, Macy, an OTCHT from Dallas. I believe her name is Erin Smith based on this, but she left us a review earlier this month. 5 stars, of course, only type of review. Said, y'all said you continue to accept Rex for show topics. What about tetraplegia, tendon transfers versus nerve transfer? Maybe with guest gurus. For sure with guest gurus. And Erin goes on to say she's currently reading about this population in rehab of the hand, and it has piqued her curiosity. So that is a great opportunity for us to have a future guest, perhaps one who might be in charge and co-leading the upcoming ASSH meeting.
There's a couple of good options. Alan Peljevich in Atlanta would be a great guest. One thing is for sure, I cannot add much to that conversation.
Great. Alan's a great guy too. And then I know that we're going to have Dr. Lindley Wall on the pod soon, hopefully, to talk about the upcoming ASSH annual meeting. And of course, the American meeting is in a Canadian country for the third time and for the second time in 3 years, but it's in Vancouver. So that's exciting.
Yeah, the meeting's gonna be great. And having Dr. Wall on will be really inspirational as far as getting excited about the meeting. So that's upcoming. Y'all stay
Absolutely.
tuned.
And I know, mate.
Y'all
Yeah.
stay tuned.
Oh, the Birmingham comes out when there are
Mm.
two of them on the pod. Macy, you're going to the meeting, right? I see you listed as a faculty.
Yes, I will be there. 2 days without young children is going to be like a vacation, and I'm looking forward to it.
Don't let
What
that time difference catch up to you,
I know. I think we're in the same session talking about nerve stuff. What else, right?
of course.
sounds exciting?
To some, and maybe not to others. But before we jump in, we should thank one of our sponsors. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join practicelink.com. Jo- I don't know. It's only been 7,000 times. Join PracticeLink for free today at www.practicelink.com/the upper hand.
You're trying to keep it interesting for everybody. Last time I had a hard time with the checkpoint copy. This time you're flubbing the practice link copy.
It was a flub. Yeah.
So we left off at one of our more recent episodes with discussion about common conditions, and we said we might talk about tennis elbow. So, uh, Chuck, I'm just going to on the fly here make up a case that maybe you and Macy can help me work through. So you have a 55-year-old gentleman who somebody just got the double nickels, maybe, and young
I
active
have
person,
I have a lot of maladies right now. Tennis elbow is not one of them, but
but
maybe it's coming.
But he was out doing the yard and was working with his weed whacker, with his lawnmower, with his hedge trimmer. Definitely not Gold Farm because he's got peoples for that. But complaining of just pain in his forearm and just can't lift anything. Has a hard time getting stuff out of the fridge. Can't work out anymore because it just hurts every time on the outside of the elbow going down his forearm. It's been a couple of weeks. Tried to muscle through, tried to use some ibuprofen, still having a hard time. He somehow gets into the office of Dr. Charles Goldfarb, who doesn't see people of that age usually, but made an exception, friend of a friend maybe. And how do you think about that, aside from automatically sending him to Macy?
So we joke, but this when one is afflicted with tennis elbow, it is no joke. And it is really it's a common condition and it's problematic. And so here's how I think about it, and I look forward to Macy's insightful comments as well. So, first it's about narrowing down the complaints because some people come in with I have pain here and they point right to the lateral epicondyle, and other people have this broad I have pain, and it often is dorsal or lateral, but can be hard to narrow down. So, really working to identify the source of the pain, and we can talk about the exam. And then once you have that figured out, then it's just about laying out options and helping patients choose, obviously, with our biases. So, Macy, how do you think about the exam for someone with lateral epicondylitis?
First, subjectively, I think about what they've been doing to irritate it and what activities of their life hurt it, because that gives me good insight if they're talking about a lot of like gripping away from the body. I sniff out lateral epicondylitis pretty quickly. Objectively, I do, tender to palpate at the lateral epicondyle. I do resisted wrist extension, which I think is a very sensitive test to lateral epicondylitis. I'll do resisted long finger extension, which is a radial tunnel test, but if they have pain at the lateral epicondyle, that points to in our clinic we say LET, lateral epicondyle tendinopathy. So I keep wanting to say that.
Sure, say it. Pretend like we were part of your clinic.
Okay, so LET, that's what we always call it. I'll confirm that they don't have cubital tunnel, medial epicondylitis. I'll confirm they don't have radial tunnel or anything going on there. And then I'll do, if I have time and I'm feeling really good, I'll test their grip strength at 90 degrees of elbow flexion, and I'll test their grip strength in full elbow extension. I'll look at and see the discrepancy and if one causes more pain than the other.
Would you
So
you would expect the grip strength to be lower with the arm with the elbow in extension
absolutely, but not because of strength, but because of pain.
because of pain? So
Mhm.
there's a lot that you said in there, and I'm sure Chuck wants you to unpack some of it too. So how do you what I've noticed is that when I talk to your therapy colleagues, a lot of people who go for a lateral epicondyle tendinopathy, tendinosis protocol also end up getting exercises that work their medial epicondyle flexor pronator mass. How often do those conditions present together? Do they present in sequence? Do you tend to treat them together, or, do you just focus on the lateral side?
I personally just focus on the lateral side unless they have like clear complaints of both sides, which is clearly a harder issue. I think that, in all honesty, exercises for this condition is not that vast. There's a small amount that I believe are, I'm sorry, I got distracted by your University of Alabama cup there. Roll Tide, first of all.
For those of you on Zoom, Charles Goldfarb was holding up a Crimson Tide coaster, a
It
coaster,
wasn't
a
even
tumbler.
for Macy. I generally drink out of a Crimson Tide cup. It's one little, tip of the cap to
I love
home
it.
sweet
I
home.
just want to say Roll Tide. Okay, what was I
Can you
talking
translate
about?
that into English for the rest of us?
Roll Tide. What
It's
was I
the
talking
long
about?
I.
The
I know.
overseas listeners are
Ah.
very confused right now.
Um,
You said you were good. You had
what
good
was I
points.
talking about, honestly?
You're talking about
LET.
how
LET?
the exercises for this are relatively limited.
Oh yeah. There's only like a few that I think are appropriate. It's not like a distal radius fracture where you could give 17 exercises in a session. There's a few that I think are specifically helpful. And sometimes if they've been doing the two or three things you tell them to do, you have this sense of like, okay, you're back, you're not better. I feel like I should give you something different. And so sometimes in those scenarios, I will admittedly give them exercises for the medial side as well, for the rationale of maintaining balance between both sides. I know that the medial side is inherently stronger than the lateral side, so you want to keep them, back to their baseline function and strength. But I typically will just focus on the lateral side.
How
Long
many
story
people end
short.
up actually needing therapy, like formal therapy for this versus if do they see you once maybe and get a home program?
I think that that first visit can be very impactful. It's a lot of talking and a lot of education, and I think a lot of people would do fine with it. But most people end up needing a few follow-ups just because patients often end up doing things incorrectly in terms of extensor stretching or eccentric exercises. We all have those patients that need more repeated instructions for various things. So I think it's a 3 to 4 visit situation for the compliant patient with good health literacy. Some folks need more handholding and ongoing care. Some clinics are required to see them twice a week for 8 weeks, so it's everybody's a little different in their approach and what their clinic protocols are.
So there's a whole lot of really important things that have been said. Let me backtrack for 1 second and say physical exam is usually not complicated. And I've said this before. For me, the lateral elbow and the proximal dorsal forearm are three diagnoses in general: lateral epicondylitis, radial tunnel, and pain in the gutter, which is intra-articular. Of course, there are other things like instability, but those are uncommon. So, narrowing it down to tennis elbow based on point tenderness, which is lateral epicondyle or just anterior to it, more distally at the radial tunnel or more posteriorly, usually is pretty straightforward. I also like the middle finger extension test. I also like just the shaking hands test,
Mm.
tells you so much. I'll say that in theory, I like the differential grip strength testing in extension of the elbow versus inflection of the elbow, but I don't find it terribly discerning, meaning most people either have pain both in extension and inflection, although I think sometimes the strength is less with the elbow extended. So I think everything you said is really important.
Mhm.
It's just important for us to say right now that if I could only pick one treatment option, it is every time therapy. And we can talk about why that is, but therapy is the answer to this problem, and time is our friend. And so our colleagues, Macy and others, are the key to helping people get better. Although I think Macy's point about how many visits and how seriously people take this all is very, very important.
Yeah, and I'll add one thing on the physical exam part. I mean, I think that I agree with the conditions that you're trying to evaluate for, whether they're competing diagnosis in the differential or they're overlapping. On my exam, I go distal to proximal because if you go first to the lateral epicondyle and all those provocative maneuvers for
Mm.
that, it's going to cause so much pain, it's going to distract from the rest of the exam. So I actually start distally in the dorsal forearm and go for the distal aspect of the radial tunnel, work my way up, maybe sometimes go over anteriorly on the other side of the brachioradialis to get to the leading edge of the to the arcade area for the radial tunnel and see if that point tenderness there reproduces some of their symptoms. And then I go for the lateral epicondyle last because I agree from the vast majority of people that's where the issue is.
Yeah, well said. So let's continue with this patient. Patient comes in. I say, "Good to see you. You're a golden age of 55." I send him over to Macy. Macy sees him 4 times over the course of 8 weeks, and he was pretty compliant with doing a home program. Now he's back in the office. He's like, "Doc, this is driving me crazy. I need to do something different." So what's next? And I'll give you options, Chris,
So
so that
hold on,
you.
time out, time out. Before we do that, can I ask one question? What kind of immobilization, if any, are you using? Do you like a wrist brace, a cock-up wrist brace? Do you like the counterforce strap kind of thing? Like, are you using anything, or is it just the exercises and anti-inflammatories?
Well, that's a great question. That's what I was going to get at next. So, and I'll turn that back to Macy. So, Chris gave us three sort of options: therapy alone, therapy with an orthotic or whatever we want to call it, or a device, and therapy with a device and an anti-inflammatory. Do you hit them with everything to start, Macy, or do you start selectively?
All three, go. Let's just nip this. I used to, well, let me back up. One of the part of my exam on the therapy side of things that I failed to mention is I want to get a pain level at rest and I want to get a pain level at worst. Not because that's going to identify if it's LET or not, but it's going to help me assess change moving forward because they note improvement is so slow that that's a measurement that I want to ensure that I follow them. So if they have resting pain, like they're watching Netflix and they actually have pain on their elbow, that to me says they're pretty flared up. And for that person, I would typically always do a wrist cock up to start and say, wear it for 2 weeks as much as you can. That's my like threshold. You're really flared. You need to just like calm things down. And this condition is really caused from repetitive wrist motion, wrist extension, and gripping. And this kind of cues your brain to just chill out and not do those things.
Which you have
Now,
to explain to the patient because like I have elbow pain. Why do I have a
right.
wrist brace?
Right, right. I'm like, why? Yeah, this is not a wrist problem. Like, it is actually a wrist problem manifested in the elbow. It's not an elbow problem. So that's a big education piece as well. But now I kind of go for the wrist brace for most people, unless it's a very low grade LET, because I think that it helps just their brain like understand that this arm needs to be rested for a period of 2 weeks or so before I can, um, get back into more regular things.
So who gets a counterforce brace? Someone who's much more mildly affected and wants to stay active?
I rarely give those, but I do give them after we've done all the things: anti-inflammatories, heat, activity modification, extensor stretching, eccentrics, the brace. That's your kitchen sink. If they're still really painful after compliance with all of those things, or they have an activity that they cannot give up, you identify the culprit. What's the culprit in your life that's causing this recurrent pain? Is it tennis? Is it childcare? Is it typing?
Is it podcasting with
Is it
Chris?
is it podcasting? I had a 17-year-old female drummer in the drum line, and I was like, well, just stop drumming. I didn't say that, but it's like, well, just modify your activities. And there's certain people that cannot do that.
I don't
So,
have anybody like that.
so for that person, I found that the counterforce brace placed along the wrist extensors can kind of help cue you when you start to engage your ECRB too much. It kind of pushes back and cues you like, okay, I'm meeting resistance with this counterforce brace. I need to not engage that muscle too strongly. So that's a rationale that I have used for those, giving the patient the caveat, don't pull too tight, because most people will pull so tight because of what was that, the gate control theory of pain, that pressure signals hit your brain quicker than pain signals do. So you stub your toe, you squeeze it and it feels better. It's like that. People just squeeze it so tight, it ends up giving them radial tunnel syndrome.
Yeah, I was
So
gonna say it's a nice radial tunnel generator, that
it
brace.
is, it is. So it's appropriate, in my opinion, for a select few patients.
I've always thought of the counterforce brace, and not the way that you've thought about it, but I think you're probably more correct than I am. But you're essentially distalizing the origin of those muscles and taking pressure off of the
Mhm.
actual origin of the mobile wad.
Mhm.
Um, but again, I've found that it actually creates more problems than it fixes
I
for the
agree.
vast majority of people.
I love a wrist cock up for this problem. Um, and I will say I have to give my colleague Tracy Keener credit. She trained me when I started on this. Her entire caseload is lateral epicondylitis. That is all she sees. That is it, with a splash of medial epicondylitis. And she loves it. So whenever my colleagues
Wow.
and I cannot fix someone, we send them to her and she fixes them.
Now I
That's
know the name to because
yeah, she's the
it's
name.
it's
It's
not it's not a diagnosis that brings me joy.
it's like having a nerve clinic. It sounds terrible.
Different strokes for different folks.
So Macy, let's say you see a patient and it's been 4 months now, and you even did a curbside with Tracy Keener, and she's like, "You've done all the right things, Macy. Send him back to the doctor." Like, what's your opinion on corticosteroid injections? And what's your opinion on surgery? When you see those patients post-injection or post-surgery, do you have a sense that it can be effective? Honestly.
I do actually. I think that it can be the appropriate option for the right person when they've tried all the appropriate things before. My experience is that it does recur um, often. So I think that patients should stay on top of the conservative strategies, including activity modification, lifting in a palm up position, avoiding too much reaching and squeezing away from the body with the elbow extended and pronated. Big one is continuing with those extrinsic extensor stretches, um, even after they get a shot or have surgery, because they can have those things and then still shorten the muscle and tendon and irritate it through those activities and then have recurrence of pain.
When I give injections, and the literature does not support them, let's be very clear. There's no strong evidence that injections make a difference. When I do it, and I will do it if people really have failed therapy, my lingo is simply that this should facilitate you to do better therapy, which can be more effective. Do not expect a single injection to be a cure because if you're not
Mm.
doing your exercises, then you'll be back here. And I think that's the right perspective.
I do too.
But I'll do it and I'll do surgery as well. I don't love doing surgery, but it feels like if everything's failed and the patient really needs something done, surgery can be effective.
I think there are really a couple of really important things that both of you just said. So Macy, some of the basic counseling that even I can give in clinic is avoiding that, lifting things in the pronated position. So teaching patients to, grab things with the thumbs up kind of position or with the palm flat or supinated. That's a huge difference, I think, for a lot of people, and it can be really helpful. And then I always remember you mentioning in your clinic when I was your fellow, Chuck, talking about, take advantage of this symptom-free or less symptom part of time after the steroid shot, to make sure that try to nip it in the bud. And I do the same thing. I tell them that, the literature is mixed in terms of how effective this is going to be, but I have found it effective for some patients, but only if they do their exercises after the shot.
Mm.
Before you
Before
jump to surgery, Chuck, what about the thing that everybody asks about? Can I
PRP,
get what Kobe got?
I
Can I
was
get the
gonna ask
PRP?
if y'all do that or talk about that.
we've been talking more about that. We do have a clinic. We try to be literature based, and there's a lot of places in St. Louis one can go get PRP injections.
They'll
Mo
inject anything, man.
They will. And insurance occasionally pays, but the vast majority of the time, insurance doesn't pay. And these clinics that do this are super busy. It's really remarkable. Um, for me, it's not a first line treatment, but if patients are aware of it and would like to do it, I think there's zero negative to doing it. I really don't think there's a negative. And I think for some patients, like steroid injections, there can be some positive. And
I
then
think this is
there's
the one indication for all of the many indications that PRP has been used for that has some reasonable literature to support it. Although there's also many studies showing that a placebo or steroid is just as effective as said PRP.
That's right. And then you have other things like shockwave, you have dry needling. Um, there may be some blood flow benefits to both of those, but I'm just not sure.
If a patient asks you how much the PRP costs if they go out of pocket, if it's not covered by their insurance, is there a general number that you give them?
Yeah, the general number is somewhere between, and it depends on the city. It depends on, and our European and overseas colleagues are going to roll their eyes, I'm certain. But I would say the general number is between 750 and $1,200 for a single PRP injection.
I tell them $1,000.
You're right in the sweet spot. Um, Yeah, and I don't know that we want to necessarily take a deep dive on surgery. I think surgery can be done arthroscopically, surgery can be done open. My general approach is simply to breed the unhealthy appearing ECRB fibers and to breed the lateral aspect of the capitellum without disrupting the lateral ulnar collateral ligament, which I think is really the only bad thing one can do with this surgery.
So this is a tendinopathy, not a tendonitis, then. Is that correct?
That's what the literature clearly states, and that's old literature. And then it questions, well, why does an anti-inflammatory make a difference? Which I think most people would say it does help. I don't know where the truth lies, but I think debriding unhealthy tissue is not a bad thing here.
I've found I will do surgery when arm is twisted, but it's usually I found it to be ungratifying
Mm.
in terms of how I feel about the surgery. But usually for me, if I'm taking somebody to surgery, it's because they have a concomitant diagnosis of radial tunnel, and we won't get into that. But I will do the ECRB treatment as part of during the radial tunnel surgery. Technically, through many of the radial tunnel approaches, you can debride the tendinopathic undersurface of the ECRB, but I find it less satisfying to do that rather than making a small separate counter incision laterally and doing it that way. I just get a better look at it as opposed to looking at it from the undersurface, although I know many people do it differently. And then maybe to close, if I'm ever in a revision surgery setting, because the patient's already had a tennis elbow surgery elsewhere, I'll make sure that it's also not concomitant radial tunnel. And then this is where I will add the denervation because I do think that works in this setting, but usually only for revision lateral epicondylitis surgery.
Yeah, interesting. The denervation procedure is interesting. If it's a multiply operated patient, I'll consider an achilles flap, which I do, once every 2 or 3 years.
It's the
Um,
only reason to use the Aconius flap is what our flap partners tell us.
well, that's the only reason I would use it. Macy, any insights on post-surgical care? Because I send these patients right back to therapy. And
Hmm.
that's the other thing we have to address in advance of a surgery. I don't want anyone thinking that surgery is going to create a miraculous cure and you're just going to sail off into the sunset. Surgery allows, in some ways, like we said, therapy, a way to restart your occupational therapy to get over the hump.
Well, before Macy tells us what she does with those patients, how long what's your post-op protocol? Are you immobilizing, or how long are you shutting them down before you send them to therapy? Because like any sportsy type surgery, it's probably some of the post-operative immobilization or activity modifications slash rest that is helping.
I've done it both ways, bulky soft dressing versus long arm splint for 2 weeks. Either way, when I see him back in 2 weeks, that's when I start therapy. This is not one of the early therapy patients for me.
So what do they do, Mace, when they see you?
So I would see them around 2 to 3 weeks for sure. And I would treat them very similarly to how I would treat like a CMC person in general, like less is more in a way. Obviously not the same exercises, but the same principles. So I don't want to go too hard too fast. This whole purpose of having surgery was for pain reduction. So let's keep that at the forefront of our minds and work on pain relieving measures in the beginning in terms of like splinting, scar massage, edema management, continued activity modification moving forward. So kind of revamping all the education that you might have gotten pre-op because it still applies. I'd probably do gentle active range of motion of the wrist, forearm, and fingers from week 2 to 4. And then I'm still one to look at like wrist flexion goniometry, compare it to composite wrist flexion goniometry, look at the discrepancy, which would evaluate extrinsic tightness. And these patients are always so extrinsically tight that I would give them like a composite wrist flexion stretch, passive wrist flexion within a symptom-free range, eventually progressing to eccentric strengthening. Grip strengthening is not one that I'll go to because it typically contributes to pain, and I don't think that the benefit outweighs the cost.
Well said. Um, I think I've talked about tennis elbow about as much as I possibly can.
Yeah, so if anybody wants Chuck to talk more about topics that make him uncomfortable, please send us an email at podcast@gmail.com. And yes, clearly there are going to be other aspects of tennis elbow care that we have not touched on. And if you have any pearls of your own, please feel free to let us know.
Dr.
Uh,
Goldfarb, did you like this session more or less than our mallet finger one that we did? You have
Yeah,
you
we all.
blocked that? Have you blocked that one out?
Yeah, I don't remember talking about mallet
We
finger
had a whole
ever.
we had a long 40-minute podcast episode about mallet finger.
Well, the good news is after we thank our sponsors, we're going to get to one of the projects that excites you, Macy, which will
Okay.
therefore give me joy.
Okay,
The
cool.
Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Successful nerve repair begins with preparation, and Checkpoint offers a instrument. Disposal instrument? A disposal instrument to aid in improved nerve preparation.
I just copy and paste, man. The Checkpoint Edge Edge Nerve Cutting Kit. Checkpoint Edge Nerve Cutting Kit employs circumferential constraint to maintain the nerve's natural shape during transection, helping to preserve fascicular group alignment and tissue integrity. To learn more, visit checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery.
I love that copy. Excellent. Well pasted. Well pasted.
Yes, yes, yes. So Macy, you are working on a couple of exciting projects. You have an international reputation as a nerve therapy guru. And you and I are working together right now on a paper that hopefully some kind editor will accept. But can you tell us a little bit more about the free functioning muscle rehab paper?
Sure, I'd love to. It's basically it's a case report, but it's basically a way to provide our recommendations on how to manage free functional muscle transfer patients after surgery. What exercises are appropriate? When do you start motion? How do you splint them? How long do you splint them? What are the precautions? And a lot of this has been adapted from nerve transfer rehab because there's just not that much out there on free functional muscle transfers, and a lot of local therapists will call our clinic or fax questions over to your office about guidelines for these patients. Because they're like, oh, we've never heard of this or treated it. And it's not uncommon because it's not the most common thing. So,
So really exciting that you're putting this out there, and like you were mentioning, not there's not a lot out there about how to rehab patients with this who have this surgery. Because while it's very common for us as surgeons in our world to talk about this, this is not a surgery that's done at many places. So what are there any particular like common questions that you get when people call you or any of your colleagues at Millikan?
it's really interesting. In the literature, I found this systematic review, I think it was 2022, and it had 39 articles out there about free functional muscle transfers. Since its very first article, I think it was in 1981, and there's zero of those 39 that mention the rehab. So it was kind of shooting in the dark, creating some sort of guideline, which is why it's based off of existing data on nerve transfers. But a lot of the questions that we get is, when can I stretch the fingers into extension? When can I stretch the elbow into full extension because it's contracted? And you see a stiff elbow and you want to stretch it, but really understanding realistic expectations on what do we hope out of this in the long term.
So to provide some context for that question, so when we're using a free functioning muscle transfer in a setting of a nerve injury, it's usually to help to restore elbow flexion. And in some cases, to not only restore elbow flexion, but then you suture it into the long flexors in the forearm to help get some element of composite flexion. It's certainly not a real fist. And then asking a free muscle transfer to do two things, both flexing the elbow and flexing the fingers, is asking a lot. And that's just basic tendon transfer principles. But yes, when we suture this in, we build in a flexion contracture in the elbow. And any therapist or any surgeon's temptation is going to, when they see a stiff elbow, to try to stretch it out. But we do not want you to stretch it out because we want that arc of motion for that gracilis, for that to help bend the elbow to be much shorter because we know we can't ask a lot out of this skinny muscle in the thigh. It's not a biceps.
So that's one question that I often get. Another question is, how long do they wear the splint for? Which is never a fun conversation because it's a very long time. It's typically until they can fire the muscle against gravity. So about a 3 out of 5, and that could be 12 months for somebody. Could be 9, could be 18. You never really know. So they're in a splint or a sling, something protecting their elbow in that shortened, protected position for a long time. So that's another question that we get.
Can I make a comment?
Yeah.
I want to bring it back to congenital hand surgery like I always do. What Chris said struck me as being very similar to the principles of the Steinler flexorplasty, in the
Mhm.
sense that the Steinler flexorplasty was designed to um, power elbow flexion by basically cutting and moving the flexor planatar mass anteriorly and laterally. And in doing so, if you're not careful, you can also cause the fingers to flex. And so trying to link elbow flexion or trying not to link elbow flexion, wrist flexion, and finger flexion is super tricky, making Macy's work that much more important, I would say.
Absolutely. And we oftentimes see patients with upper trunk injuries use their Steinler effect to try and flex their elbow. And if that's how they flex their elbow, fantastic. But, if you're trying to restore true elbow flexion from something like a biceps brachialis, reinnervation technique like an Oberlin, or do it through, a gracilis. But the Steinler flexorplasty is a nice thing to use in the plexus world as well. I know some of our colleagues in Charlotte, Glenn Gaston and Brian Loeffler, have had a lot of success with that, as have many other places who have used that before the advent of nerve surgeries.
Sorry, Macy, did I disrupt your train of thought?
No, not at all. That was earlier. That's past. So other questions that we get, let's see. Somebody, is used to seeing a orthopedic injury like a TFCC repair or a distal radius fracture, and therapy's over by 10 weeks or 12 weeks. They're good to go. And then in the same context, they're like, oh, they haven't made progress. It's been 10 weeks. We're going to discharge them. And so having that understanding that it's a much longer recovery, we might not see results for 12 months, 18 months. So it doesn't have to be twice a week for that length of time, but having some sort of check-ins and not discharging them so quickly because you need to understand that it takes a while.
Yeah,
Thank you.
and it can take a while for some of these, especially if we use intercostals as the neurotizer. That can take a long time.
Hmm.
But we tried to use spinal accessory for that, at least in our practice. And nice paper from Alex Shin's group up at Mayo Clinic and JHS a couple of months ago, demonstrating that volitional control on the free functioning muscle is better with spinal accessory as a donor as opposed to intercostals. But sometimes you don't have that option.
Hmm.
So Mace, do you have a preference if we had to pick one donor? Should it be our spinal accessory? Should it be our intercostals? And how does that affect the rehab?
Definitely spinal accessory. I think it's very intuitive if you just say sit up straight, retract your scapula. You can tell that their gracilis starts to tense up and fire, and they're like, oh, whoa, I didn't know it does that. And you have to teach them, you have to use this donor action to give your elbow and fingers the ability to move. So I think that that is my favorite for sure. And if you just tell them to sit up straight, retract their scapula, and like have good posture throughout the day, I think it's just a really good reminder. Um, and intercostals is okay. It's just not quite as intuitive. You have to have a lot of exercises in supine to work on trunk flexion, exhalation, inhalation, trunk rotation. So it's just not quite as intuitive. And it takes
So
longer, as you mentioned.
as we bring things to a close, first off, we have to have you back again. So many topics to explore, but I think you have an exciting announcement about something that everybody in the hand therapy and hand surgery world is going to want to add to their virtual or real bookshelf.
All right. So since October of 2022, my colleague Lorna Khan and I, and you, Dr. D, have been working on a clinical manual or resource for surgeons, new surgical trainees, and therapists primarily to create kind of a resource guide for nerve transfers from the scapulothoracic joint all the way down to the fingers. And so it's basically like the Indiana Protocol book, but for nerve transfers. So if you get a referral for a nerve transfer you've never seen before, rather than Googling or asking questions on the phone to your physician's office, like what exercises do I do? What are the expectations? Can I have some sample ideas for exercises or handouts? It's all going to be there. It'll have a table of contents where you choose a transfer and you look and see, okay, this person has a 2 minus or a 3 plus or a 0. What postoperative, protocol should we be abiding by at this point?
So where's the book going to be available?
On Amazon. It's actually already on Amazon and the picture's there. It just says coming October 17th, I think.
Is this
So
self-published?
It is not.
my role in this, aside from writing some introductory text about each of the procedures, was to help Lorna and Macy secure a book deal. I did that. I did my job. And then, I mean, Lorna and Macy have done an incredible amount of work. I mean, I've seen the proofs. They look awesome. There's great. They secured illustrations for the book. So all of us surgeons who give talks, you can, look in there and obviously with Macy and Lorna's permission, use the illustrations. And then it has photographs of the exercises, so this is designed to be a one-stop shop for therapists anywhere who can pick this up, not have to go scour the internet, and just show this to patients. And I believe you guys are trying to get some handouts that are going to be available online to go along with this. So you can give,
Mhm.
exercises to patients, which I think is going to be an incredible advance.
That is, let me just say, really, really awesome work. This is a niche void, uh, but will be widely sought after. So congratulations! I can't wait to see it. I will bring it back to congenital one more
Oh,
time.
God.
Got to do it. I also wrote a therapy book with therapy colleagues. I don't know if either of you guys bought
Wow,
one.
add to cart. I think I have it. I think it's somewhere collecting dust. You might have given it to me as a graduation gift.
I didn't give them away to anybody. It's like the St. Louis Protocols for pediatric and congenital therapy. I wrote actually it was the process started probably 40 years ago with Lorna Daly, not Lorna Daly. Oh my gosh. It started 30 years ago or 40 years ago from the Shrine, and we have updated the protocols, and Michelle Burke and I worked super closely on this, and it was a real contribution. And I did self-publish. I didn't want to deal with a publisher, so I think you probably did it in a better way. But it's this, I'm excited for you guys. This is really, really cool, and I know it's going to be well sought after.
So Macy, tell us what people should type into Google or Amazon in order to get a copy of the book. What's the name of it?
Rehabilitation. What is it called?
Macy, we have to get you ready for the road show. You're gonna be doing press junkets everywhere.
Rehabilitation, nerve
For
transfer. No, wait. Nerve transfer rehabilitation following brachial plexus injuries.
it
No,
says
that's not right. That's not right. I don't know what it's called.
it's
Type
re
in.
it's rehabilitation for nerve transfers of the upper extremity.
That's what I said.
That is not what you said.
Yeah,
Well,
so type that into Amazon, it'll pop up.
I'm hoping that this. I don't think it'll come out in time for the Vancouver Hand Society meeting. Hopefully, it's out in time for the ASHT meeting. And I guarantee you, if you bring Macy a copy of the book and a Sharpie, she will sign it for you. Same thing with Lorna.
For sure. And it's published by Springer. We should give
Yes.
kudos where kudos are due.
Yes.
Not
So
a sponsor.
Macy, not yet. Springer, if you're listening. So, Macy, thank you for joining us yet again. If you are listening and you have other topics you want Macy to discuss with us, let us know, handpodcast@gmail.com. And Chuck and Macy, I hope you guys have a wonderful night.
Please do the same. Macy, thank
Yeah.
you.
Yeah, thank you.